Okay, Dr. Tom Townend is we're very pleased to have here tonight. He's a angelic man who is a general paediatrician with an interest in allergy and eczema. He's a member of Allergy and Eczema Clinical Network and the Paediatric Society Allergy Special Interest Group. Fun facts about Tom: if he wasn't a doctor, he might be a zoologist. And he's a dad of three crazy clowns, one of whom is the current 2020, wait for it, players' player of her hockey team tonight. Thank you. Round of applause, Tom. And Tom will be talking about eczema and food allergy.
Thanks, Anna. And thanks, Annalise. It was a masterclass in keeping to time, so I will try and do that as well. So stopwatch starts now. So I'm talking about eczema and food allergy, and arguably I probably should have made eczema in great big font and food allergy in little font, because that is how my talk's going to flow. Oh, I can click, can't I? Don't need to work here. Here we go. And this is the rough outline of what I was going to cover. So it is going to be heavily weighted towards eczema. And so we'll talk about what eczema is, the pathogenesis of eczema, management of eczema, and when we cover that, I'm going to draw quite heavily on work that has been done through the Eczema Clinical Network. There's a couple of really good videos. I'll show a couple of examples, but I'll also show you quite a few of the resources that I think many of you would find quite useful in general practice. Another aspect of primary care, I'll particularly deal with topical steroids because steroids and steroid phobia is a pervasive issue. Then eczema and food allergy, the reason it's so far down the list is because often as not, the connection is not as clear-cut as people would think. The role of allergy testing, and then at the bottom, food allergy / dietary considerations, some of which crosses over quite nicely with what Annalise was talking about. It's a fairly busy slide, apologise about that, but yeah, eczema affects 30% of children in Australia and New Zealand. It's an incredibly common condition, and it has huge impacts on the lifestyles of the children, but also of their parents. And it's unrelenting. And just when you think it's relented, it comes back again. In terms of a definition of it, it really is dry, itchy skin with an impaired skin barrier. The skin barrier is not functioning normally, and associated with that, you've got inflammation and risk of infection. It's not curable, but you should be able to control it, or at least control it reasonably well. And there are a whole range of things that trigger it. But as you'll see down the bottom, rarely is it food that's the trigger. So the eczema pathogenesis, I'm not going to get too scientific about this, but there are a whole lot of factors involved. And some of those will be intrinsic to the skin barrier itself. There are a number of genes identified coding for different proteins in the skin, and if you're deficient in those, you are at increased risk of eczema. They may lead to defects in the innate immunity response or a Th2 skewed adaptive immune response, and Annalise referred to the Th1 versus Th2 situation. I'm a paediatrician, so Th2, you're in the poo, which tends to make the kids smile. They also have altered skin microbial flora, which is another major factor in how we manage it. A lot of this is still hypothetical. We don't exactly know. So some people favour the inside-out hypothesis, where immune dysregulation on the inside feeds into skin barrier dysfunction and inflammation, and other people like outside-in, whereby it's the barrier dysfunction leading to skin inflammation. Or maybe it's a combination of both. One thing that we do find quite useful, so we have an eczema allergy nurse specialist here in Christchurch who does a whole heap of work with families and out in primary care, and she finds this model particularly useful, but it's used up and down the country as a way of explaining to families what's going on, and then that leads in quite nicely into what are we going to do about it. So it's called the brick wall model or brick wall hypothesis, and basically this is the stratum corneum, these little blocks, and the blocks are corneosomes, skin cells. And the little joiners, the little grey or bronzy coloured things in between them are the connecting proteins. I should have pointed out the bottom is the inside of the body, bottom of the slide is the inside of the body, the top is the outside world, and the looser packed skin cells at the top, closer to the outside, and they're constantly being shed and new ones are replacing them. And the whole point of this skin and skin barrier is to keep irritants out and keep moisture in. And so if you've got dry or diseased eczematous skin, what you'll see is, and what we explain, is that basically that barrier is starting to break apart. So you're seeing that more water, more moisture is creeping up through the gaps between the bricks, and there's more spaces that irritants can sneak down through. You add soap and you further weaken those bonds and further provide more irritant. And so the whole thing's really starting to look a bit shaky and come apart. The bricks aren't held together anywhere near as well. And so infection and allergens and irritants can come in, causing inflammation. And we find that really quite useful. You can come across this model in many eczema resources that you'll find online. Because then it flows through quite nicely into this. So what does an emollient, a moisturiser, do? Well, it provides a block. So it's a thick film running across the top there, which is keeping the irritants and allergens out and keeping the water trapped in the skin. And that's eczema management in a nutshell, or at least eczema prevention in a nutshell. This is the first of the videos, and we'll run it.
There are 3 really important steps when caring for your child with eczema. Moisturiser. The more often you use it, the better. Use lots of moisturiser. Use it at least twice a day, more if possible. Use it all over the body, including the face. Bathing. This can be really helpful. Bathing once a day cleans the skin and prepares the skin for creams after the bath. Use a moisturising wash or soap substitute. Don't use soap or bubble bath. Pat the skin dry. Don't share towels. Apply eczema creams immediately after the bath. Steroids. These are really important if your child's skin has active eczema and is red and itchy. Steroids can help to soothe the skin and allow it to heal and become comfortable again. Steroid creams are safe and essential for eczema care. Use steroids on any skin with red, itchy, active eczema. Stop steroid creams when the eczema has gone and start if the eczema returns, but keep using moisturiser every day. If your child still has red, itchy, active eczema, please see your doctor or nurse.
So that video, one of the good things, and you'll see in my slide on resources, is there's a lot of good agreement amongst different organisations up and down the country in terms of the messages we're getting across, and so there's quite a lot of good sharing of information. In these videos, that's Diana Purvis talking there, paediatric dermatologist in Auckland. These videos are on the Kids Health website, but they link through to YouTube, so they're really accessible for anyone, and they're really useful. I mean, that is the message in a nutshell, and you can give parents the website addresses and send them on their way, and they can look it up and watch it over and over and over again. I'll just go through the various steps in a little bit more detail. So bathing. Bathing is a way of soaking moisture into the skin physically, and also lifting off dead skin cells, and it hydrates the skin in preparation for subsequent eczema treatment. We encourage people to bathe every day, or bathe their children every day in warm water for 15 minutes or less. Unfortunately, there's a sort of a counterproductive effect that happens if you sit in the bath for too long. Anyone who's done it in recent times, you get those wrinkly fingers. The beneficial effect sort of becomes becomes counterproductive and the skin opens up too much and you can lose too much moisture. So up to 15 minutes. Don't use soap. Soap's an irritant. No child with eczema should use soap. Use a soap substitute, which is an emollient. Antiseptic baths. So altered skin flora is a feature of eczema, and one way that we can dampen down that overgrowth of bacteria, particularly Staph aureus, is with regular use of antisepsis. And one of the best things we find to do this is standard bleach, and it's standard bleach, ordinary bog standard, cheap as you can get bleach. There's a few options on the right hand side there on a bleach bath information sheet, which again is readily accessible through the various websites in New Zealand, like Kids Health. You don't want to use Genola or anything. I'm not picking on Genola, but you don't want to use one of the ones that is full of fragrances and bubbles and other interesting things. You just want bleach. And bleach in bath water at an approved dose is a very effective way of decontaminating the skin. And we'll often suggest that people do it daily in the middle of an eczema flare, but twice weekly in between times is a great way to keep on top of things. And then after the bath is the time to put on your eczema therapies. Moisturiser all the time, steroids if you're actively treating with steroids. Whether you put on the moisturiser first, then the steroid, or the steroid, then the moisturiser, doesn't really make a difference. Some people have preferences, but there's no evidence behind it. Moisturising is moisturise, moisturise, moisturise. That is the key thing for managing eczema. The skin's too dry, you need to moisturise it. And you moisturise every day, and you moisturise multiple times a day. You've got to keep the skin moist. The pump bottles, like Sorbeline, or any of the pump bottle moisturisers are great because you don't contaminate them. The ones that come in tubs, if people dip their fingers in, then any bacteria that were on the parent or child's fingers are now living in the tub, and cross-contamination is an issue. So if it is in a tub, spoon it out, spoon onto your fingers, then onto the child. Apply generously. You would have seen in that video, or you can watch it again, Diana was smearing the moisturiser on in the direction of hair growth. That's a nice soothing way to do it. And use enough. So a 500 gram tub should be gone through in no more than 2 weeks. And that means if you're prescribing moisturisers to the kids with eczema, prescribe 3 kilos, prescribe 4 kilos, prescribe 5 kilograms. Tell them to pick up a box full from the pharmacy. They're just bucket loads of it, because that reinforces the message of use it like it's going out of fashion. Moisturise, moisturise, moisturise. They come in a range of thicknesses. We don't use lotions. Lotions are too thin and they don't work. So you've got creams, fatty creams, or ointments. And on the side there, what you're showing is as you get thicker, the effectiveness increases, but unfortunately compliance can drop, just because they feel a lot stickier down at the bottom end here. But these are all fully funded, and sometimes the kids' families will use a blend of them, different times of the day, or depending on how their eczema is, or or eczema on different parts of the body. I think I'll come back to that point later on. But now the second of the videos I just wanted to show is steroid specific.
Punamu's eczema has flared up. If your child's skin has active eczema and is red and itchy, steroids can help to soothe the skin and allow it to heal and become comfortable again. They are used alongside other important eczema treatments, particularly moisturisers and avoidance of soap. Topical steroids come in different strengths, and the choice of steroid to use will be made based on the degree of eczema and which part of the body it's on. Make sure you speak with your doctor or nurse who prescribes the treatment so that you understand which part of the body each cream is meant to be used on. Apply steroid creams to areas of active eczema once or twice a day. The best time to put these on is straight after the bath or shower before or after the moisturiser. Apply steroid creams just to the skin which has active eczema, not to the entire body. Enough so that we can see just a nice shiny layer over the skin like that. A little bit more up here. When the eczema has gone away and the skin is no longer red and itchy, you can stop using the steroid cream. Continue to use moisturisers though. The fingertip method can be a helpful way to work out how much topical steroid cream to apply. If cream is squeezed out on the tip of your finger from the first joint to the end, this amount of cream is expected to treat this amount of skin, the size of 2 palms of your hands. Remember, steroid creams are safe and essential for eczema care. Use steroids on any skin with red, itchy, active eczema. Stop steroid creams when the eczema has gone and start if the eczema returns, but keep using moisturiser every day. If your child still has red, itchy, active eczema despite using steroid creams, please see your doctor or nurse.
So I showed the whole video there, partly to show how long they are. They're really good, short little video clips, but also because it's so good. Penny tells me the reworked versions of these available in more languages are in the pipeline, but at the moment they're only available in English, aren't they? Yep. So just to touch on those a few points again about steroids, and I'll spend a bit of time on this because steroids can be tricky. Basically, the steroids are treating the inflammation component of eczema. That's the redness. And you can't get on top of eczema flares without using steroids. They are safe and effective when they're used correctly. They come in a range of potencies, as Dinah said, and we use the different potencies on different parts of the body depending on the type of eczema you've got, how severe it is. We don't usually use more than 1% hydrocortisone, which is the lowest potency we've got, on the face or the neck. We'll very rarely step up to the next step. And steroids are used once or twice a day, on the most part once a day, and once is usually enough. There's no additional benefit from using it more than that. I can skip through a lot of this because Diana's touched on it, but the key thing is to start using the steroids as soon as the eczema starts to flare. Try and get a lid back on top of the eczema as soon as you possibly can, putting it on straight after the bath, before or after the moisturiser. As she said, you need to use enough. You need to use enough to get a shine on the skin. The fingertip unit, which Diana modelled really nicely in that video, and I'll show on the next slide, is a way of quantifying this for people. So it's the adult finger, and as she pointed out, a fingertip should cover the equivalent surface area of 2 adult hands. There are other ways of working it out. There's a chart that's based on the rule of 9s, and so for people that are familiar with managing burns, that can be useful, but that 2 hands is about the easiest to use. And then you stop the steroid when the eczema flare is resolved, keep on moisturising, and then restart the steroids when the eczema comes back, because it almost certainly will. So we haven't cured the child's eczema by treating their flare. We've controlled it, and chances are it will come back, and then we just do this again. These are the fingertip units. So what you'll see is one fingertip unit is about 0.5 grams. And so I'll come back to that because that has implications in terms of, well, how much should you be prescribing volume-wise. I've said prescribe moisturisers like it's going out of fashion. Well, you almost need to do steroids the same way. There are various steroid ladders of potency that you'll access in the various resources. These ones are steroid preparations that are available in New Zealand, ranging from hydrocortisone down the bottom there, all the way up to Dermol up the top. And you'll see that Dermol is 600 times as potent as hydrocortisone. The potency, you make that decision based on where on the body you're treating, and the reason being that we have different skin thickness, so we'll only use 1% hydrocortisone, occasionally Aristocort on the face. Body, you can certainly go to potent or very potent, such as Locoid, and palms and soles of the feet. If you've got bad eczema there, you're likely to need to start with a super potent product just to get penetration of that very thick skin. Skin folds that you are naturally occlusive, and so you get enhanced absorption of the steroid, and therefore you don't need as much potency. And so you aim to use the lowest potency steroid that's effective for that individual child's eczema on that individual child's part of the body. And then you can often, as not, step down potency as the eczema resolves. Steroids, sort of like moisturizers, come in a range of preparations or thicknesses: ointments, creams, lotions. The ointments are particularly good for young children because they don't care if they're greasy. In fact, they quite like it. And really the only risk there is they'll get so greasy, out of the bath, covered in slippery ointment, that you'll drop them. And that's a problem. But other than that, go for gold with the greasiest, smeariest ointment you can find. They give the best absorption of steroid. The middle ones, the creams, are really good for the school-aged kids because they can take it to school themselves and they're reasonably happy to have it in a tube and squirt it on themselves, provided they know how much to give, and if they need to be doing that. School, I suppose, is not the good example, but if they're going to stay with someone else for the night, or they're going on a school camp or something and they're administering it themselves. And then down the bottom, lotions for hairy people or hairy parts of the body. They penetrate a bit better, so on the scalp especially is quite useful for using lotions. So this comes back to that whole fingertip unit being 0.5 grams of steroid. So you've got to anticipate how much volume you're going to want to prescribe the child so that they're not back in your GP practice or wherever you work the following week because they've already run out, because they used it like we told them to use it, and then now they've run out. So let's say he's an 8-year-old child and he's got diffuse eczema affecting all 4 of his limbs and his trunk. Well, we just add up the fingertip units that he's likely to need. So 2.5 for each arm and hand, so that's 5. 4.5 for each leg and foot, that's another 9. The front of his trunk's 3.5, his back and buttocks is 5, and so he's needing over 20 fingertip units, which is 11 grams a day. And so a 100-gram tube of Locoid might last him 9 days, and that's assuming he doesn't waste much of it. It's not very long. So he might need a few tubes in the prescription. Steroid phobia is something I wanted to talk about. So it remains an issue in the minds of many people. But we just need to reinforce the message that steroids are safe and effective when they're used appropriately. And the days of prescribing them used sparingly are long gone. There is no rationale for doing that, no sense really in doing that. They are a medication, they have a certain dose and should be used in that dose. And so another thing, the potency of the steroid reflects its pharmacodynamic effects, its chemical composition. So if you dilute a potent steroid, you don't make it less potent. And what that means is in the likes of hydrocortisone, there's actually very little difference between 0.5, 1% or 2% hydrocortisone. It's the same potency. Skin thinning is probably the most common side effect that people are worried about with steroids. It rarely happens when steroids are used appropriately, and usually it's a misinterpretation of ongoing eczematous inflammation. To get significant systemic absorption, which can happen if steroids are used inappropriately, you need to be taking whacking big doses. So getting through 500 grams a week of hydrocortisone, yeah, I'd want to know about that. Yes, it is. Yeah. There's a reference down the bottom there which is readily accessible online, links from various places, that is well worth reading if you've you've had any concerns regarding the prescribing of topical steroids in the management of eczema, or if your patients remain concerned or hesitant about using enough. It's quite short, it's 2 pages. It was based on an article that was published in 2015, and then this consensus statement came out in 2017, and it sort of addresses the various concerns quite nicely. And there are spin-off patient education leaflets and other resources. How long do you carry on using the steroids? Well, as Diana said, in most cases, you can just stop it when the inflammation resolves. I do actually often tell the parents to just carry on a few more days afterwards, though, because at a histological level, there's probably still a bit of inflammation when you can't see it on the skin. So basically, when the eczema stops, a couple more days, then stop. How long should you use them for before you're really starting to get worried that this child's eczema isn't responding? The super potent steroids, no more than 3 weeks continuously, and the moderate to potent, no more than 3 months daily. Then I think we need to take another think about the patient, and do they need systemic treatment and referral onwards. This poster here just came out a month ago, or a couple of weeks ago actually. The CDHB have our dermatology and pharmacy colleagues have put together. And the problem with the steroids and many of these things is that they change. Pharmac changes which ones are funded, or the steroid or the companies change which ones they're bringing in, or they change the packaging, and the patient comes to you and says, I'm on the gold one or the blue one. So this is valid as of now. It won't be valid in 6 months' time perhaps, but it's quite useful. It comes as a poster. It's certainly available for anyone who's got access to the Canterbury Health Pathways, Health Info sites. From further afield, I'm not sure how easily accessible it would be, but of course you'll get it as part of this presentation. Eczema follow-up. So I find it really helpful to make use of parents' phones. It's not showing very well on the screen in the room here, but the parents can take sequential photos and reaffirm for themselves how the child's eczema is going, but also convey that to you. And then there are other ways of doing it, such as the poem scoring, which is again accessible through the Clinical Network website, and I'll give you that website. It's a 2-page way of quantitatively scoring the severity of the child's eczema. This is quite useful if you're seeing the child over time, so you can plot how they're going. It's quite useful if you're referring on, so that you can say, I've done all of this, and their poem score is still 26. That means something, and certainly our local dermatology service will use this as part of their management as a way of deciding whether the child's responding to the therapy they're on or whether they need to step up. These are this is not all of the resources you can find, but these are all really good. They're all well regarded by paediatric dermatology, specialist nursing services in New Zealand. I'd recommend that you use them, refer your patients to them. There's a lot of patient-specific stuff on there. And finally, towards the end of my talk, we'll talk about food allergy. So the thing is, people with eczema often have other allergic conditions, including food allergy, but food allergy rarely causes eczema. Eczema is not IgE mediated, and as you saw in Annalise's talk, if it's not IgE mediated, it's not causing IgE mediated allergy. I sort of say eczema and food allergy are different manifestations of atopy, and I'll show you a slide that I used to describe that. But basically, just because you've got an allergy, what am I trying to say? Just because you've got eczema doesn't mean it's caused by your allergy, even if you have allergies. I often hold my hand up to families, point to my palm and say, imagine you're atopic, and then I point to my fingers and say, and different manifestations of that are asthma, allergic rhinitis, eczema, food allergy. Unfortunately, I've only got 4 fingers and I've got 5 fingers, so I always just have to tuck one in. But a way of showing that, okay, you might have all of these things, but that doesn't mean there's a causal relationship from one to the other. You are atopic, You inherited that from your parents, most likely. But then people will say, but my child's got eczema and they've got allergies. Surely they're linked. And of course, there is correlation here. So most young children with food allergy have eczema. And children with eczema are at increased risk of developing food allergies. And Annalise touched on this as well. And so it's quite good we're cooperating here. 30% risk of future food allergy in infants with eczema versus in kids without eczema, only a 10% likelihood of future food allergy. And what the evidence increasingly shows is that if we manage eczema well during early infancy, we can potentially reduce the child's chances of developing future food allergies. And how does that work? Annalise alluded to this, but this is the hypothesis which talks about, well, what's the difference between being exposed to things cutaneously versus being exposed to things orally? And it would suggest that we are designed as young babies to put our hands on everything and put those things in our mouths. And whatever it is, food, poo, goes in our mouths and we generate a tolerant Th1 response. Whereas exposing ourselves to things via the skin route and skin draining lymph nodes, we're more likely to generate an allergic Th2 response. Parents often say, well, I want to introduce foods to my kid. Can I just smear a little bit on their skin? And the simple answer is no, for these reasons. So if you smear it on the skin, you run a very high risk of exposing the child to that particular potential allergen through the wrong route. And if anything, encouraging the development of sensitization and food allergy. There is I have a bit of a concern, and many of us do actually, about people using all sorts of food-based moisturising oils, coconut oil, potentially olive oil. We do see quite high rates of coconut allergy. Whereas the mouth is designed to have stuff put in it. It's a naturally tolerogenic environment. So get them to eat the food, not smear it on. Eczema and food allergy. So because the food allergy is almost certainly not causing the eczema, and because because a positive test result may just be showing sensitization, not true allergy, we strongly encourage people not to test for allergy unless there's an extremely good reason. And even if you do test and you identify positivity, that doesn't necessarily imply allergy, let alone causation of eczema. And what we want to do is avoid inappropriate or unnecessary food exclusions. This LEAP study was a really important study that came out in 2015, and the follow-on was a year later, LEAP On. And it was a UK study, and they took 640 children considered at risk of peanut allergy, and they were considered at risk because they'd already been found to have egg allergy, so already had one food allergy, or they had severe eczema, and they were aged 4 to 10 months. And they randomised them to peanut consumption or peanut avoidance through to age 5 years. And at age 5 years, there was a stunningly different rate of peanut allergy between those who'd been eating it over the previous few years and those that had been avoiding it. Then in LEAP, so that was fantastic, reinforcing the importance of getting food early into an at-risk population. And then a year after the kids turned 5, they tested them again and found that benefit was sustained. So it wasn't just while you're consuming peanut, you're protected. That tolerance that they had developed was sustained, and we would hope will be lifelong. So if you're remotely interested, those 2 studies are articles that we should all read. So when should you introduce foods? Well, this is more information here from other studies, and there are many studies now. Our allergy advice over the decades has swung around a bit, and I accept that. However, it's really nicely stuck now on early introduction of foods, that we are most likely to develop tolerance to new foods in infancy, early infancy. So 4 to 6 months of age is the time to start introducing foods of all types. Egg, peanut, fish, cow's milk, wheat, if, despite all of that, the person in front of you is convinced that the child eats food and their eczema flares up, it's still possible. The way to find out will be to take the food out of the child's diet. But we shouldn't take that on lightly, because what tends to happen is people take a food out, and that didn't work, so they take another food out, and that didn't work, so they take another food out, and then another, and then the kids aren't eating anything. Or people think, oh, maybe it's food, so they test, and they test a wide number of foods, and several of them are positive, so they take all of those foods out. So unless you've got a strong history of food exacerbation, we generally don't advise removing foods. Certainly shouldn't base it on a test result, and we wouldn't advise doing it in breastfed infants. There's a very real risk that you take a child who was just starting to establish tolerance, you deprive them of that food, they miss out on that developmental window, immunological developmental window for developing tolerance, with potentially fatal outcomes. I don't think we've had any fatal cases in New Zealand, but I've had several kids who were most likely tolerating a food. It was then taken out for whatever reason, and they are now highly allergic, including anaphylactic. And then there are nutrient deficiencies and compromised growth if you're taking out multiple key foods, which the front row here are fully aware of. So how do you approach potential food allergy in a child with eczema? Well, generally still recommend introduction of all foods at 4 to 6 months. And if they don't have any evidence of a proven IgE-mediated allergy, then we need to weigh up the risk of managing their eczema versus causing allergy or depriving them of nutrients. As Annalise said, if you are taking a food out, it's for 2 weeks, maximum 4 weeks, and then you have to reintroduce it, because an improvement that you see within those 2 to 4 weeks may well be coincidental. So they have to close the loop, reintroduce it. And then absolutely, if you see signs of a non-IgE mediated allergy, intolerance, when the food is reintroduced, then sure. But we need to balance what we're doing here still, because you might well argue that if you can manage their eczema through aggressive eczema management and keep those nutrients in their diet, then that's a reasonable balance to strike. It doesn't have to be all or nothing. Most children, even if they are having these food-related flares, will outgrow them, and so re-challenging them on a regular basis is important. Hey, wow. Pretty much on time. So that's all I wanted to cover. So we do have time for questions.
Great. Thank you very much, Tom. That was excellent talk. Just what questions have we got from the audience? Oh, great. I'll hand you the microphone.
Yep. Sensitivity. So the question was, what do we do when they go out in the sun? And a lot of these eczema kids are quite sensitive. And fortunately, these days there are an enormous range of sensitive skin-oriented sunscreens available, and the sun blocks tend to be best. So the zinc-based sun blocks sit on the skin. It's a physical block, not a chemical reaction. And many of the big companies produce, they've got nanoparticles of zinc, so it's no longer the whole sort of look like a ghost approach. They are cosmetically acceptable to anyone. And yeah, so we strongly encourage that. Obviously it gets tricky if you're putting on if your skin's already greasy from your moisturisers and you're trying to put on your sunscreens, so covering up. I mean, if you're having to apply moisturisers so frequently that getting a sunscreen on is going to be challenging, then put a hat on.
Any other questions from the group here tonight? Yep, hang on a moment.
I was just curious, just seeing you're a paediatrician, regarding probiotics in children, and if there's any research to do with eczema result and things like that.
There's no... yes, so just in case it didn't come through the mic, the question was about probiotics, the role of probiotics in managing eczema. So probiotics, there's no good evidence of benefit. There is no evidence of of harm. It's certainly not becoming a widespread thing in the management of eczema. There's a lot of work being done if we're talking eczema and food allergy and atopy. There is work specifically looking at trying to do something about all of these allergies, so immunotherapy. And unfortunately, oral immunotherapy for food allergies has not progressed beyond the laboratory in the year 2020. But one of the things that they are looking at is probiotics as an adjuvant for getting the foods into the gut as a way of encouraging a tolerant response. So no, I'm not aware of any beneficial or evidence-based role specifically for eczema, but it is something that is being studied. Yeah.
Great, the whole microbiome story. Thank you, Tom. Any other questions from the group here? We've got a few online questions. Okay. One question, which is something that I think I hear a bit as well. Parents often report rebound after stopping the steroid. What would you say to that, Tom?
So, yep, there was a little bit in the media in the last couple of weeks relating to that sort of thing up in Hawke's Bay. There are children certainly who their eczema just immediately comes back when you stop the steroids, and I guess that just shows that we haven't cured the problem. It's still there and it will recur. In those, I often find a step-down approach quite useful, and so rather than going cold turkey, your inflammation's gone, stop the steroids, but stepping it down and saying, okay, you were doing daily, now we're going to drop you to 4 times a week, or a way that's easy to remember. Or maybe you'll have it 5 days a week and the weekend off, and we'll do that for 2 weeks, and then we'll drop it to 3 times a week, and then we'll drop it to twice a week. And you can usually wean them down like that. There are some who, despite all our best efforts and the best parental work in the world, they're just constantly at risk of re-flaring. And in some of those, weekend therapy is really useful, whereby they continue using steroids regularly 2 days a week, and it doesn't matter if they're consecutive days or split, and so the weekend is often quite good. So you have a specific bath routine on the weekend. On the weekend you have your bath, you moisturise, and you apply steroids Saturday and Sunday, and just giving 2 days a week like that really drops down your overall exposure to steroids, but is enough to potentially keep a lid on things. So it's usually manageable. Yeah.
Another question, Tom, is what to use on the eyelids when there's eczema. Is it safe to use hydrocortisone?
So, yes, and pimifeucort is another option. So that's an immune thingy. Pimicrolimus. Yes, if you've got periorbital eczema, then yes, it needs treatment.
Another question here is there any reason that eczema keeps recurring at the same site of the body?
Yeah, well, there are parts of the body that just seem particularly prone to eczema. So there's presumably something about the skin on those sites which makes it likely, and something about the skin on those sites in those children. So we don't know what that is. But yeah, in some kids it will keep coming back in some sites. There are different types of eczema too. Some kids have it just in their flexures, some have it far more diffusely, and some kids have those really discrete plaques, and the rest of their skin might actually be beautifully moisturised, but they just have these resistant plaques, and there's some local thing about the skin in that area that means that eczema's got established, and those plaques often need really highly potent steroid to get on top of, and intensive moisturisation because the skin's just so thickened and inflamed.
Maybe just one last question. Someone's asked to if you could say a little bit more about the negative effects of using coconut moisturiser.
Yeah, well, it's just it's a food protein or food substance that you're then putting onto damaged skin, and so based on our thoughts about incorrect exposure of the immune system to foreign substances, this is not proven, but you would have to be quite suspicious about high rates of coconut allergy that we're seeing. Where are these kids being exposed to the coconut? because in some of these families, coconut is not a common food, but they must have been exposed to coconut somehow to become sensitised. You have to have been. And so, yeah, it's something I would be concerned about, and it's certainly trying to... The moisturisers that we use are incredibly bland. I sort of describe to people, don't think of them as medications, just slather them on. You cannot overdose on moisturisers. And so when we've got substances which are known to be safe and effective and useful, I don't encourage the use of food-based oils or moisturisers.
Certainly seems to be a bit of a false belief that chemicals such as the things that we prescribe for moisture on skin are more harmful than foods, which is clearly in this case not.
Yeah, whilst coconut is more natural than inert moisturisers that have been made in a lab, that just because they're natural doesn't mean that they won't cause allergy. All of these foods are natural foods, and we see what they do.
If I can chime in, I would completely agree with you, Tom, there as well, that, you know, we're seeing it, even oats are used in oat soaks, almond, coconut, those kind of things. And I often also say to families that some of those food oils actually suck water out of the skin instead of keeping it in, so it can be another way of just suggesting it might not be the best thing.
Thanks.
Great, thanks, Annalise. Oh, we've got one more question just from the group here.
We use kawakawa. So what is your idea on that?
Well, so the question there is about kawakawa-based preparations, and I have to admit I don't know much about that. Certainly as a trigger, I don't know if you do, Annalise, feel free to chime in, but as a trigger for allergy, no, that doesn't seem to be a problem because there's no particular allergy to cause. So I'm pretty relaxed about that, to be honest. If someone's using it, they feel they're getting benefit from it, provided, as Annalise says, it's in a thick enough preparation that they're getting meaningful moisturiser. I wouldn't want that to get in the way of effective moisturisation. It's not as good, an oil like that, or if it's an oil base, it's not as good as the other substances that we've got. Is there anything wrong with it? Almost like the probiotic argument. No, if you think it helps and you want to use it, carry on.
I totally agree, Tom. That's exactly what I say to my patients, particularly around the, like the probiotic management. Don't understand everything about the gut microbiome yet, and if it's not doing any harm, then I don't have a problem. And I agree with you, as long as it's a nice thick moisturiser, it's actually doing its job, then I don't have too much of a problem. I see a lot of patients using kawakawa balms now.
Okay, well, thank you very much, Tom. That was very informative.